Hi, welcome everyone. This is Dr. Sharad Jaitly, cardiologist from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is a site which is dedicated to educate you about the human heart and its illnesses and is committed to improve the clinical outcomes by combining patient education with medical education across the globe. So thank you again for watching and associating with MuniMeterHealth.com, your favorite website on health, heart, and illness. Without any further ado, I'd like to delve into the subject matter, and the matter of the subject today is what is cyanotic heart disease, and we'll take the prototype as Fallot's, the Fallot's tetralogy. Fallot's tetralogy, or Fallot we call it. And it has, obviously, as it says, tetralogy, so it should have 4 pathologies, if you will, and that's a short form for tetralogy. And Fallot, of course, was the first person who was able to define this condition so accurately in those years. So let's understand how the heart looks like in a congenital setting of Fallot's, if you will. Now, I'm drawing the right side. And as you go here, there's a large VSD, so that's a defect. Here's the RV, if you will. Now, aorta happens to be right over here, and it seems to be overriding, if you will. I'm going to show it like an overriding. And the pulmonary artery, which I'm going to show in the blue if I can, yes, is actually kind of squeezed in. And it has a huge stenosis, if you will, and that's the infundibular stenosis in the pulmonary artery. And the pulmonary artery, actually, it goes up like that. Obviously, it's behind and then divides into 2. And they're very small arteries, if you will. Now, the left atrium, we're going to again show the boundaries of the left atrium here on this side. And then is a smaller atrium, and the left ventricle is also small. We're going to show a smaller left ventricle than the right ventricle here, purposefully in my schematic, because RV is the big guy here, is the big brother. Okay, and then the mitral valve tends to be arising from this area and then this area. So the aorta is just juxtapositioned right there. So what is happening is, now if you will, you were to draw the shunt will be from right to left, if you will, and that's where the shunt is. So the blood is going around like that, and most of the blood is also going into the aorta. So aorta gets a feed from both angles. One, obviously, you have the oxygenated blood, so-called, coming in, so that'll be going in here. And then you have the deoxygenated blood also, which is going in here. So you have deoxygenated blood and you have an oxygenated blood, both going into the aorta, contributing to the cyanosis, if you will. So cyanosis is one of the features. I'm drawing it, writing in blue, but primarily because obviously it's a central and peripheral cyanosis where the extremities are blue, and they will be clubbing. These are the other features, if you will. And patient will be dyspneic, obviously, because of lack of oxygen. And again, remember, this is present in neonates and pediatrics, and in very young age, it's pretty much diagnosed, because it's Fallot's tetralogy is not compatible with life if it's not corrected. So, but if it is corrected, then you have an excellent prognosis, because you have 85% survival beyond 35 or fourth decade, if you will, or 35 years or fourth decade, if you will. Here I'm showing the right-sided valves. These are tricuspid valves. So the pulmonary artery, as I said, so the primary let's see the primary features. The primary features of Fallot's are, number one, you have a large VSD. So there's a large VSD. The second feature here is the pulmonary stenosis, and normally it's at the pulmonary valve level, or it could be at the infundibular level, as I have infundibular level. And along with this, there could be pulmonary atresia, pulmonary truncus arteriosus, sometimes anomalous pulmonary drainage can occur here. In other words, oxygenated blood can come back here. One of the pulmonary arteries, pulmonary veins rather, can bring back the blood, and the oxygenated blood is coming back in here. So it's a lot of anomalies can exist. And then invariably the pulmonary artery, which normally arches, it may also have the aorta, which may be arching to the right instead of to the left. So the aorta actually may arch to the right, if you will, like that. So it may go like this, if you will. So that'll be the aorta. So those are the two primary features. What have we learned so far? Remember, there are 4 features. So large VSD, pulmonary stenosis, and the third feature and the fourth features are secondary features, because now you have a right ventricular hypertrophy as a result. Why? Because there's a pulmonary stenosis. The blood is not able to be pumped. So this guy, the right ventricle, I call it, it becomes a big brother here and tries to push. So right ventricle is huge. So there is RVH. And then the fourth, obviously, is the overriding aorta, as we just talked about. So the overriding aorta is, these are the secondary features, if you will, because the RVH pushes the septum more further towards the left ventricle, and this becomes big. So as a result, you have a right to left shunt and the overriding aorta occurs. So these are the two secondary features, the right ventricular hypertrophy and overriding aorta, if you will. But the primary features are large VSD and pulmonary stenosis, which is at the pulmonary valve or in fundibular level. And that constitutes the Fallots of tetralogy. Okay, so having defined this, now let's understand what are the, the genetics. Genetics are very important, because now we have learned so much about genetics. It's the chromosome number, if you will, 22. Try to remember it, because it might be on the boards. They might give you this. And it's 11.2q. So chromosome 22, 11.2q is the site on the chromosome which has the micro deletion, remember, if you please remember that. And that constitutes the cyanotic heart disease. So it's one or the other. So, so you'll have a micro. However, this abnormality of the chromosome, the anomaly, is present only in 15%. It's not present in all of them. 15% of the Fallots will have chromosomal abnormality, which is 22.11.2 Q, if you will, on the Q site of the chromosome. Now, genetic counseling, that's because genetic is important, so genetic counseling is important because Fallots now are living longer, so we have to give them pregnancy counseling as well. So one of the things to remember is if one of the parents has Fallots, tetralogy, and obviously is now, and the offsprings, and they get pregnant, and the parents, the woman gets pregnant, the genetic counseling suggests that there will be a 50% chance of developing this chromosomal abnormality in those offsprings. Remember that. If one of the parents already has this. But if none of the parents have it, then the chances are only 4 to 6%. So it drops rather 4 to 6%. If none of the parents have it, then it drops to 4 to 6%, this chromosomal abnormality. Otherwise, it's very, very high, remember that. So obviously, genetic counseling is so important, specifically to the young parents who are, if one of them has a Fallots tetralogy. ECG will show certain changes, and we can just move up a little bit on the page, if you like, and draw it here. So the ECG will show RVH pattern, there'll be a right atrial enlargement pattern, and there'll be a P pulmonale, which is tall P waves. You'll see really peaked P waves, and then QRSs, but the peak tented QRSs will be there. So just remember that this P wave will be very, very tented. Chest X-ray will clearly show, especially on PA and lateral. Lateral will be the key because remember, right ventricular hypertrophy occurs anteriorly. Left ventricular hypertrophy occurs laterally. So where will you see it? In the lateral film more than the PA film. So you'll see RVH obviously, and you'll see the pulmonary artery is extremely small. The pulmonary arterial tree, if you will, is small, is diminished because there's hardly any blood going through the infundibular stenosis, the pulmonary stenosis there. Okay, and heart murmurs will be heard, predominantly the pulmonary stenosis, which is a systolic murmur. Sometimes the right to left shunt will be heard, but because the shunt is large, I mean the defect is large, so the murmur is not that prominent from the right to left shunt, but more from the pulmonary stenosis, and then return back on the mitral side, the diastolic rumble, if you will. Echo will be the clincher because echo will be the diagnosis right there, and echo will define clearly what's going on in these patients because you'll see the overriding aorta, you will see the RVH pattern, you will see the RA enlarged, and you will see the pulmonary stenosis, and you will see obviously the large shunt from right to left that could be recorded as well. So all the four features of the echoes will be diagnostic here. Treatment plan is surgical correction obviously, and then most of these patients will require repeat surgical corrections, primarily because the pulmonary stenosis can redevelop and VSDs have been reported to recur, and RVH tends to worsen at times. RV and LV diastolic dysfunctions can develop. So these are some of the later complications, but normally the recurrent surgeries are also very successful. But just in a nutshell, remember that Fallot tetralogy is the commonest cyanotic heart disease, and therefore we discuss this as a prototype. Polycythemia, as usual, strokes can develop because of the microcytes being extremely rigid. They can't pass the capillaries. And iron should be supplemented once the hemoglobin returns back to normal. Then at that point, iron could be discontinued because you don't want to have an iron overload in these patients. But phlebotomy is the way to go, specifically for polycythemia, because polycythemia is a huge issue because of secondary hypoxia phenomenon. Okay, hope you enjoyed the discussion on Fallot tetralogy in this short video. Again, the goal is to try to give you the maximum information, both for the boards and for the exams. Please supplement this with your texts, with your Max app, with your other articles, and of course with the journals. And more current knowledge will still be continued to be offered in the subsequent videos. Thanks again. This is Dr. Sharad Jaitly from New York on your favorite website, MuniMeterHealth.com. Please continue watching.